Welcome to this webinar on addressing pressing health and wellness issues for people at risk of or living with metabolic diseases. I'm your host, Dr. Neil Skulnick, professor of family and community medicine at the Sidney Kimmel Medical College of Thomas Jefferson University. This special webinar is sponsored by Corcept. And joining us for today's episode is Dr. John Buse. Dr. Buse is the Vern S. Cavanis Distinguished Professor and Director of the Diabetes Center at the University of North Carolina at Chapel Hill School of Medicine. He has been President for Medicine and Science at the American Diabetes Association, is a recipient of the ADA Outstanding Achievement in Clinical Diabetes Research Award, has authored more than 500 publications and participated and led numerous clinical trials. And if I didn't shorten all of his qualifications, we'd have no time left to talk about the topic today. Welcome, John.
Well, thank you very much.
John, we've been charged with discussing pressing health and wellness issues for people at risk or living with metabolic diseases. That's obviously a very broad topic, and certified diabetes care and education specialists are our primary audience today, and they have a unique role in promoting wellness for people at risk of or living with metabolic disease. What do you think are some of the most important challenges we face today in promoting wellness for people at risk of or having metabolic diseases? And if you can think of two or three that you'd like to discuss, and then we'll kind of take them one at a time. What would be the first one you'd like to tackle?
I mean, sort of starting at the beginning and going to the end, I think arguably the biggest opportunity in all of sort of the diabetes metabolic disease space is to recognize people at risk who have not yet developed diabetes with an aim to intervene to prevent the development of diabetes and these complications. And then the second part of it is when you look for people at risk, you will find people who didn't know that they had diabetes, but that early recognition of diabetes with an aim to achieving remission, making the diabetes just go away. I think that's number one.
Yeah. And I agree with you. Before we go on to number two, if we may, just let's do a little bit of a deep dive there, because that's so critical, and I'm so glad you mentioned prevention. And how do we identify those people who are at high risk or early on with diabetes?
Yeah, so it's a relatively recent thing. The last 2 or 3 years, the U.S. Preventative Services Task Force decided that screening for diabetes and pre-diabetes was worthwhile, so insurance plans cover it. And the idea that their recommendation was anybody with overweight or obesity, so a BMI over 25, and most people over 23 in Asian Americans, to screen for diabetes starting at age 35 or earlier in people with a bigger burden of risk factors, which include, other cardiometabolic diseases like hypertension or high triglycerides, low HDL, those kinds of issues, family history of diabetes. In those populations, you'd start even before age 35 with screening tests.
Yeah, and that's so important because that's a lot of our patients. So it really lets us put out a pretty big net in terms of finding people at risk. And then that next piece of this first issue is when we find those people with an A1C of 5.7 or above, what do we do?
Yeah. So the way I handle it, the general recommendation is lifestyle management, or in people with sort of high risk markers or markers of good response to metformin. Well, in general, it's lifestyle management, proven very effective in multiple studies done on basically every continent. Metformin has a good track record, particularly in younger patients, people that are heavier, and people with higher levels of fasting glucose or hemoglobin A1C, women with a prior history of gestational diabetes. And then not as directly recommended because the evidence isn't quite as strong, but probably the best data for preserving beta cell function is with the glitazones, and probably the very best data for preventing the progression, at least as long as you stay on the drugs, are these highly effective GLP-1 receptor agonists like semaglutide and tirzepatide.
Yeah, the tirzepatide pre-diabetes trial from last year in the New England Journal was really just amazing. I think it went 2 or 3 years, but a greater than 90% decrease in progression from pre-diabetes to diabetes in the treated versus placebo groups. That was amazing. And John, I think probably my personal favorite trial of all time was the Diabetes Preventive Program trial from the New England Journal 2002, showing the benefit of lifestyle modification. And I know that we both are believers in that.
Yeah, so the lifestyle modification reduced the risk of developing diabetes over 3 years by 60%. Metformin was only about a 30% reduction, but in the younger patients that, those less than 45, I think was the cut point, or with a BMI greater than 35, there it was more like 60% as well with metformin. But the reason I think it's such a huge opportunity is that there are 100 million people in the United States with prediabetes, is the estimate, and only 10% of them know it. So if we did a better job of screening people in primary care practice as on a routine basis, if they're overweight and over 35, or if they have multiple risk factors even earlier, we
Wow.
would have a huge opportunity to prevent the development of diabetes.
Yeah, that really is enormous. And then people have a choice whether they want to emphasize just lifestyle and medicines, and enormous opportunity there. So that's our first big area. Second,
Well, well, and then
yeah.
there's also the second part of that first big area. So
Hmm.
there's about 35 million people in the United States with diabetes, and about 25% of them don't know it. So when you're
Huh.
screening for prevention, you will find some people with full-on diabetes. And there's good data, again, with the drug therapies that we have and lifestyle therapies that we have, that with 10% weight loss, you have a very high rate of remission, just making the diabetes go away early in the course of diabetes. If you wait 10 years to make the diagnosis of diabetes, it's tougher. We can treat diabetes whenever we diagnose it, but the best outcomes come when you treat it early and basically you make it go away.
Yeah, such an important point. So that's our first big area, prevention and picking up diabetes early on in its course. Next area.
Second area, which I think the diabetes educator community have a unique opportunity to contribute to, is to have consistent engagement with people living with diabetes over their lifetime, with enough time and effort to really review their lifestyle plan in detail, how they eat, how they exercise, how they sleep, what kind of social supports they have, and their medication plan with a focus on adherence and persistence. So people are really good at getting on the bandwagon and taking care of diabetes for weeks, sometimes months, but rarely years. And so that people need help. And the diabetes educators, because of the amount of time that they have at a quote visit to spend with people, they can get into the weeds and really find the kind of supports that people need to be able to persist in their good diabetes behaviors across the board, not just lifestyle, but also medication taking.
It's so important. None of us can do it alone, and having someone that cares and is involved over time makes such a difference. Next area.
So uh, as soon as you make the diagnosis of diabetes, even in the pre-diabetes era time frame, cardiovascular risk is already emerging. And so evaluating all the comorbidities and complications of diabetes on a consistent basis, or making sure that that gets done. And that's daunting because it involves everything from checking blood pressure, checking lipids, checking liver function tests, making sure people are going to the dentist, getting their immunizations, having their cancer screenings, et cetera, et cetera, et cetera. People with diabetes are at all kinds of risks, having their eye exams, having their foot exams, the urine albumin to creatinine ratio. There's a lot of stuff to do that is, needs to be reviewed on an annual basis. So making sure that people get the across the board kind of primary care evaluation, and particularly for diabetes educators that are involved in healthcare systems, they can really be instrumental in that process. The primary care doctor gets 10, 15 minutes with a patient, and having someone that can go through the checklist and just make sure it's all done is incredibly helpful. Early detection of complications, a little bit like early detection of diabetes, you can nip it in the bud. Same thing with these complications. If you detect it early, super easy to take care of. If you detect it late, often we're talking about disability or early death as a consequence.
Yeah, it really is something. As you're mentioning complications, just three so quickly come to mind. Looking at a simple foot exam and being able to advise people if they have early peripheral neuropathy. And just the last few years, what we have to offer people with chronic kidney disease or with early symptoms of heart failure is just so much. And we live in just such an amazing time to be able to intervene as long as we think to ask the right questions, do the physical exam, and as you said, catch things early. An interesting area that's emerged recently are underlying endocrine disorders that we now need to be aware of because of how they influence both how people feel day to day as well as their clinical outcomes. Can you tell us a little bit about these emerging areas?
Yeah. So that's my fourth thing. And my fourth thing is to recognize atypical cases. And what I mean by that is, prediabetes, finding prediabetes to work towards prevention, finding early diabetes to work towards remission, making sure to screen for all the complications. But if there's someone who's developing complications or you just can't control their diabetes, back in the day, we used to say, well, they must not be adherent. They're not doing what we ask them to do. I think 9 times out of 10, maybe 99 times out of 100, they actually are. So to me, the atypical cases are people that just don't seem like all the rest and looking for atypical causes. So the number 2 cause would be that people actually have type 1 diabetes and not type 2 diabetes. That's 5% of people with adult onset diabetes. But the new thing that we've just discovered, it's really in a way sort of rediscovered, but hypercortisolism is present in 25% of people with difficult to control type 2 diabetes, people on multiple drugs with a hemoglobin A1C greater than 7.5%, or 2 or more drugs with complications. 25% have hypercortisolism. And that would be impressive enough, except we also showed that if you do cortisol-directed therapy, in fact, the average patient's A1C went down to around 7%, and they had a reduction in the need for diabetes medications. So a remarkable response to cortisol-directed therapy in this, quote, difficult to control population with hypercortisolism.
That is amazing. And that's not something that I think most of us are aware of. And we've talked before about this, and you've made the point that it's not only control of their A1C for these people, but that often it's a more global improvement. Is that right?
Yeah. So the things that we measured in the trial were A1C reduction, and it went from an average of about 8.5 down to about 7. With the mifepristone was the cortisol-directed therapy that we used. The placebo had minimal effect. But they also lost 5 kilograms of weight in 24 weeks, 5 centimeters of waist in 24 weeks, and that was headed down. I don't know how, I don't know what to expect over 3 to 5 years of cortisol-directed therapy. But more of a sort of anecdote is the patients that I've been involved with. To me, the most impressive thing is, there's this sort of neuropsychiatric overlay to hypercortisolism. Many people are anxious, or, they have problems with excess sweating, or, just feeling unwell, nervous, depressed. And people just got their life back. Their diabetes became easier, they lost weight, but they just felt so much better.
That really is amazing. We've covered a lot of ground here, from early detection of prediabetes to early detection of diabetes, all we can do there, detection of complications. And even in less than 20 minutes, we talked about unusual cases and what we can do there as well. Dr. John Buse, it looks like you had another
Yeah,
thought there.
I mean, just for the diabetes educator community in particular, I think a lot of these patients end up being referred to the diabetes educator, sometimes for help with initiating insulin or other more advanced therapies, but often because, the primary care doctor's sort of at their wits' end that, I don't know how to help this person. I keep prescribing medications and they don't get better. So please, if you see people with challenging diabetes, do think about this 1 milligram overnight dexamethasone suppression test. Ask the primary care doctor to order it, and check to see if they have hypercortisolism.
John, that's such a good point, because we in primary care really do look to our colleagues, our diabetes educators, to advise us what to do. And we so welcome those recommendations. Dr. John Buse, thanks so much for joining us.
It's always a pleasure, Neil.
And for the American Diabetes Association, thank you for joining us. And stay tuned for other webinars and short bite learning that helps us all to stay up to date and continue to give high quality care to our patients.